So today we're going to be talking about Ethambutol. As you know, Ethambutol is a medicine that is used for the treatment of Mycobacterium. And worldwide, the most common indication is for Mycobacterium tuberculosis. But in the United States, we have a lot of a different type of Mycobacterium, which is Mycobacterium avium complex, MAC, or Mycobacterium avium intracellularis, and a whole host of other different species. So both the treatment of TB and MAC use Ethambutol. It's super important that you know about Ethambutol because it causes vision loss as a side effect. It's usually painless, progressive loss of vision. It's central, and so it produces a central scotoma or a secocentral scotoma. They have decreased acuity, and usually there's no finding on the exam. So the nerve looks normal initially. It's a retrobulbar optic neuropathy, and then it becomes pale over time. So we never want to have the person end up with optic atrophy. We want to diagnose the patient before we get to the optic atrophy. Once the nerve turns pale, the chance of recovering the vision is low. And Ethambutol toxicity is a dose-dependent phenomenon. Once you get above 15 milligrams per kilogram, you're going to be entering into a toxic range, but there is essentially no safe dose of this drug. And as opposed to hydroxychloroquine and chloroquine, which are cumulative dose dependent, you can lose your vision from Ethambutol in the first 2 weeks or first 2 months. And so we have to follow the patient very closely in the beginning, especially once you start getting into numbers like 25 milligrams per kilogram or greater. And sometimes the loading dose for MAC is very high, and they might be in the numbers like 25 to 30 milligrams per kilogram. So those patients are at particular high risk, especially if they have renal disease. So we should dose adjust the Ethambutol if we have renal disease. And patients with MAC and tuberculosis, they tend to lose weight over the course of their treatment. And many of our MAC patients are actually transplant patients. And so those patients are going to be frail and losing weight, and their mgs per kg might be going up because their kilograms is going down, not because we're actually giving them more medicine. So we should tell the patient that if they have vision loss and they're on Ethambutol, that they should stop the medicine, and we should examine them. Obviously, we're not the prescribing physicians, so we should call the primary and the prescribing doctor before making any adjustment in the medicines. And because there's no pre-screening abnormality, it's not like hydroxychloroquine where we can do MERG or spectral domain OCT or Humphreys. Really, the only thing we can do is say yes or no, you're having decreased vision. And so somebody has to check their vision every month. It doesn't have to be you, it doesn't have to be an ophthalmologist, it doesn't even have to be an eye care provider, it just has to be somebody. And so I give them a copy of a Snellen chart on a piece of paper that it was copied, and we give them an answer grid to check themselves. So if there's any decreased acuity, we're going to bring them in, we're going to do a field, we're going to be looking for the central scotoma, we're going to do an OCT, we're going to look for optic atrophy, but hopefully we won't see any of that. If we stop the medicine early enough, it's reversible. If you don't stop the medicine early enough, it'll just keep progressing, and the progression can occur for months after discontinuation of the medication, which is a little bit counterintuitive given the half-life of Ethambutol. In patients who have TB and have INH on board, if they continue to lose the vision after stopping the Ethambutol, we might also stop the isoniazid INH. In MAC, the other MAC drugs don't usually cause vision loss, so pretty much it's limited to Ethambutol.